Right, good evening, everyone, and a very warm welcome to the Cardiac Ultrasound May Talk series. Today is the third installment in a series of five talks, and we have the pleasure of hosting Professor Roxy Senior from the Royal Brompton Hospital in London, UK, this evening. So due to the large number of attendees, we will have everyone on mute throughout the presentation. I'm thrilled to have you all here for this educational opportunity, gathered from across South Africa, Kenya, Egypt, and other parts of the world. I appreciate that you made the time to join us this evening. My name is De Wet van der Westhuizen. I'm an advanced cardiac ultrasound application specialist for Philips in the Africa team. Let me address a couple of matters before we begin the lecture. And during the lecture, should you have any questions for Professor Senior, please type them in the Q&A section that you will find either at the top or the bottom of your application, depending from whether you are tuned in from your laptop, your tablet, or your smartphone. And we will do our best to address all the questions during the Q&A session at the end. Saying that, we may not make it through all the questions, but we will attempt to identify as many unique Okay, we will, we may not have time to answer all the questions, but we will attempt to answer at least as many questions as possible, and at least try and answer all the most frequently asked questions. So as you are all aware, the World Health Organization has declared the coronavirus outbreak a global health emergency. We realize that COVID-19 has disrupted our world in many ways, and we also believe that learning and education should not stop even in these very uncertain times. And from the onset of this pandemic, we have been brainstorming ideas on how to help with continuous education. Investment in education and its ongoing development is an essential part of the Philips strategy to better serve its customers and to improve quality. As a leading ultrasound health technology company, Philips has a broad portfolio of products such as ultrasound for cardiac and lung imaging. Allow me to highlight our premium cardiac ultrasound platform and some of its applications. The Philips Epic CVX is our premium platform designed for cardiology. It offers tailored applications for adult, pediatric, and interventional echocardiography with faster data processing, sharper imaging, robust automated quantification tools, and a customizable 2D and 3D user interface. The revolutionary Insight imaging architecture provides images with exceptional frame rate, uniformity, and penetration. Usually 1 + 1 would equal 2. However, in this case, with this very strong combination, 1 + 1 is 3. As most of you will surely know, TomTech is now part of the Philips family. In the next slide, I will show you how we have seamlessly integrated some of TomTech's most trusted applications onto our Philips platforms to bring to our users fully automated and easy to use quantification tools. So firstly, I want to highlight our comprehensive auto strain solution. The clinical benefits of strain echocardiography are well established, and echo societies around the world are advocating its routine use. In the cardio-oncology setting, global longitudinal strain, or GLS, has been identified as the optimal parameter to detect preclinical left ventricular dysfunction. Philips has a comprehensive strain solution for the left ventricle, for the right ventricle, as you can see, and also for the left atrium. All of these are in alignment with the EACVI and ASE Speckle Task Force recommendations. All these applications are fully automated and produce global and regional strain curves within seconds. The second application that I want to touch on pertains to 3D volumetric assessment of the left heart. The dynamic heart model is, it removes the complexity of 3D left heart quantification. It's a fully automated tool that quantifies left heart volumes and ejection fraction within seconds. The beauty of this is that image acquisition is very easy, the analysis time is fast, and the results are robustly reproducible, allowing you to incorporate 3D into your routine clinical practice. It now gives me great pleasure to introduce our speaker for this evening. Professor Roxy Senior is an internationally recognized authority in echocardiography. He is Professor of Clinical Cardiology at the Imperial College in London and Director of Echocardiography at the Royal Brompton Hospital in London, UK. He is also Director of Cardiac Research at the Northwick Park Hospital in Harrow, UK. Professor Senior has led 3 multi-center trials in myocardial contrast echocardiography, which were instrumental in this technique being in guidelines in both Europe and the USA. He's also instrumental in popularizing stress echocardiography through major publications and is regarded as an international authority on this technique. He's one of the first to show the cost effectiveness of portable echo for screening for heart failure in the community. He developed the concept of transaortic flow rate for the assessment of severity of aortic valve stenosis. Professor Senior has published nearly 400 peer-reviewed manuscripts with an H-index of 60. Of these, he is senior author in more than 50% of them. So Prof, it's an absolute pleasure and an honor for us hosting you this evening. Thanks for your time and welcome. I think before I give over to you, it will be very useful if we can understand, if we can get to know our audience a little bit better. So we're gonna bring up a quick poll, and I will ask delegates if you can please tell us who you are. If this is the first time for you, fear not. This is actually very easy. Click on the appropriate answer, and then if you can click submit, this will just give us an idea of who's on the call, whether it's cardiologists or cardiology training fellows, if you're a clinical technologist or a specialized physician, cardiac anesthesiologist. Please tell us who you are and click submit. While we wait for the results, just a reminder that all these webinars are recorded and they are posted on our dedicated MedTalk YouTube channel. So a few days from now, you will receive an email and the link to that recording will be on that email. We will also ask you to kindly share your feedback, right? We are always after ways to, to make this better. If you are, for example, if you're after a specific talk, please suggest something that if you feel it will be beneficial to your practice, and we can definitely see where we can help. For South African attendees, you will get CPD points, so please complete the 5 questions for us and we will email you your certificate. Excellent. Okay, the results just came in. All right, Prof, so it seems we have so quite a lot of clinical technologists or cardiac physiologists, and then a couple of cardiologists, a few trainees. Excellent, thanks for that. Prof, without any further ado, I'm going to stop sharing my screen. If you can share your screen, you can unmute, and then over to you. Thank you very much.
Okay, I'm sharing my screen now. Okay.
Okay.
So yes. I go to slide mode.
Excellent, Prof. Thanks.
Okay. So I'll just
all good.
Minimize this. Okay, so David, thank you very much for inviting me to give in South Africa from London. London is boiling hot today here, while I think South Africa. So my topic is assessment of discordant aortic stenosis. What is discordant aortic stenosis? So if you look at slide, the criteria of severe aortic valve stenosis and an aortic of less than 1 centimeter, or what is discordant hemodynamics. So you can see here the discordance lies in the fact that if you look at the first one, that the mean gradient suggests severe aortic stenosis, but the valve area suggests the stenosis is because it's more than 1 centimeter square. And the other discordances where the mean gradient suggests that it's not severe aortic stenosis. The valve area here suggests that it's severe aortic stenosis. So this is what we see in about 30% of our patients who are referred to us for aortic stenosis, meaning discordant hemodynamics. And we need to assess this very carefully to understand two things. One, what is the severity of aortic stenosis and what is the prognosis in this group of patients? So now, why do you think there's a discordant hemodynamics? Why should the gradient be less than 40 and AVA is also less than 1 and vice versa? That is because both the gradient and the aortic valve area are flow dependent. Now, this is looking at gradient, transvalvular gradient versus transvalvular flow. And you can see here that, so if you look at these two curves, the red and the green, the red is somebody with aortic stenosis on the borderline of being severe, that's 1 centimeter square, and the green is 1.5 centimeter square, meaning it's moderate. If you look at the area between the two, you will see that as the transvalvular flow rate increases in patients who do not have severe aortic stenosis, you will see that at some point when the transvalvular flow rate is increased to about 375 or 350, the mean gradient is more than 40. So in other words, this is a patient who has got moderate aortic stenosis, but high transvalvular gradient, moderate aortic stenosis, but low transvalvular gradient, but when the flow rate goes up, the transvalvular gradient exceeds 40. On the other hand, if you look at the curve here, which is blue, which is a patient with severe aortic stenosis, as you can see, the gradient is very high, about 80, 60, etc. But the same gradient drops to only 20 when the flow rate is down to 125 ml per second. So that is the reason, main reason for the flow, the discordant hemodynamics, that the flow rate could be high, could be low. So how do we, so when we define aortic valve stenosis, it's fine to say mean gradient is more than 40, it's fine to say AVA is less than 1, but as you can see, there's another parameter that needs to be assessed, and that is mentioned in one of the older editions of Bronwell's book, which was not paid much attention to. As you can see, it says at a normal cardiac output. So we have to assess the flow alongside the mean gradient and the aortic valve area, and I'll come to that in a more detailed manner. So let's look at the discordance where the gradient is high and the aortic valve area is suggests moderate aortic stenosis. So as I've said, it's related to flow. Now there are two situations it can happen. One where the high flow is reversible and the other where the high flow is irreversible. So when you look at the patients who had reversible high flow, the reasons for those patients having high flow is because they may be septic, they may be anemic, they may be thyrotoxic, shunts because of dialysis. And so we don't jump up and down and say, oh, this patient's got high gradient, we need to do something about the valve here because the gradient is high. Now, all we need to do is to correct those factors, treat the sepsis, correct the anemia, treat the thyrotoxicosis, and then, flow rate will come down and the gradient will reduce, and now it will become concordant. So we don't need to do anything apart from treating the underlying condition. But however, the patients who've got moderate to severe AR, there the high gradient is irreversible in the sense that you cannot reverse the high gradient unless you replace the valve. So here the treatment, though it is discordant, is more because the patient's got aortic regurgitation and that is impacting on the gradient, and the gradient is impacting on the left ventricle, putting more load on the left ventricle, so the left ventricle is bound to suffer in the future. So now this patient will need valve replacement. Now there's a third group of patients where the gradient is increased, but it is falsely increased. And there's a condition called pressure recovery because of a small ascending aorta. When the aorta is small, the pressure in the aorta recovers very quickly. And when the pressure recovers very quickly, it means that the pressure in that area drops while the pressure in the LV is high, and then you get a very high gradient. Now, in order for you to assess that, first of all, it mostly occurs in patients with the aortic root being less than 3 centimeter. So if you see a patient with high gradient with the aortic root of less than 3 centimeter, then you need to calculate energy loss index. Unfortunately, it's a rather long formula, but it takes into account the aortic valve area and ascending aorta area, and then it derives a figure here by dividing it by body surface area, and you get a valve area of 0.57 centimeters square per meter square. If it's less than that, then it is severe. This patient truly has severe aortic stenosis. If it's more than that, the patient doesn't have truly severe aortic stenosis. Now, this condition is not very common. That's why I'm not going to go into the details of that. It's uncommon to have such very small ascending aorta and such huge pressure recovery. So moving on. So let's move on to a low gradient, but low aortic valve area. So mismatch in the other direction, where the gradient is low, but the aortic valve area suggests it's severe aortic stenosis. Now here, the first thing that you need to do is to recheck all your measurements which affects your determination of severity of aortic stenosis. And one of the major factors that affects the severity of aortic stenosis is transvalvular gradient. So we must make sure that we have got the highest gradient before we declare that it is discordant. And also we need to be sure that the aortic valve area, as you can see, has got lots of variables in the continuity equation. And one of the major variables that affect the aortic valve area in a big way is the LVOT diameter, because here the LVOT diameter is being halved and then it's squared. So a small error in measuring LVOT diameter can give rise to big changes in the aortic valve area. So you can reduce it or it can go up. So one needs to measure very carefully the left ventricular outflow tract diameter. Now you need to measure the LVOT velocity also correctly. And I'll come to how you do that. And finally, if the patient is small statured, even if the aortic valve area is less than 1, if you correct it for body surface area, the aortic valve area could be within normal range, meaning more than 0.6 centimeter per meter square. So if you see a low aortic valve area in a small statured individual, assess aortic valve index area. And if that is more than 0.6 centimeters square per meter square, then you have made a diagnosis of non-severe aortic valve stenosis. So now let's come to each of those points, particularly transvalvular velocity. So this is an example of a patient where we put the, where we are imaging the patient apically, and you can see that Doppler, angle Doppler across the aortic valve in this view. And it's more or less parallel to the jet, but you see a velocity of maybe just 3 meters per second. Now, suddenly we see a velocity of 6 meters per second. So what happened here? So all that happened was we've moved the transducer from the apex to the right parasternal area in the second intercostal space, and we've put the transducer there. Now you can see that we are imaging from there, and the jet is going in the direction of the transducer, and therefore you're getting a nice jet in parallel. And now you can see it's 6 meters per second, a huge difference. And this, I can tell you from my experience, it occurs in 15 to 20% of the patient with the so-called low gradient. So when assessing gradient, if it is low and if the valve appears a bit calcified, you must do the other views. But I would suggest that you must do, look at all the other views irrespective, because you want to assess the highest gradient. So even if the patient has severe aortic stenosis, say 4 meters per second, or say a mean gradient of 45, and the patient is asymptomatic, but if you assess it from the right parasternal view, the gradient is as high as this patient, even though the patient is asymptomatic, will need the valve replaced because they are now at very high risk. So I would recommend that you do that in all your patients of aortic stenosis. So moving on, how about the LVOT diameter? Now, as I've said, LVOT diameter is the greatest source of error for calculating aortic valve area. And according to guidelines, it says you can measure the aortic, the LVOT diameter in any of these 3 points, and they don't really vary. But if you look at the study, which has been very recently published, actually just about maybe a month back, you will see that measuring LVOT diameter at the annulus or very close to it provides the most accurate measure of stroke volume or LVOT diameter. And this is in comparison to MRI. And actually the advantage of measuring LVOT diameter at the annulus is also that you know your landmark. So the landmark is the junction of the hinge point of the right coronary cusp and the anterior septum. And from there, so it's a very easy landmark. And from there, you just drop the line and see that it is parallel to the plane of the aortic valve opening, and you get an accurate LVOT diameter or consistent LVOT diameter assessment. Now, you can have a patient where you're measuring, say, if you look at the image here on the left side, there's a blob of calcium sitting here, and if you measure from the hinge point to here, it will be abnormally low. Now, at this point, what you should be doing is to just move the transducer a little bit so that you get rid of the calcium. Now you get the true LVOT diameter. Now, regarding the LVOT velocity, now you can see that the LVOT velocity has to be correctly measured, because if you put the sample volume, which should be not more than 3 millimeter, more towards the apex, the velocity will go down and you will overdiagnose severe aortic stenosis. On the other hand, if the sample volume is on the aortic valve itself, then you will go into the phase where there is flow acceleration, and you will overestimate the area of the aortic valve area. So it should be at a point about 3 millimeter, just below the acceleration point. So 3 millimeter from the cusp, just below the acceleration point, where you see the aortic valve closure. That gives you the most accurate LVOT velocity. So having attended to all those and making sure that you've done it correctly, then you diagnose low gradient aortic stenosis with a low aortic valve area. Now, at this point, we need to define transvalvular flow. And as you all know, according to guidelines, the transvalvular flow is defined as stroke volume index less than 35 ml per meter square. And if the LV ejection fraction is less than 50%, it is known as classical low flow, low gradient aortic stenosis. And if the ejection fraction is more than 50%, it is called paradoxical low flow, low gradient aortic stenosis. Paradoxical because the ejection fraction is normal and yet the flow is low. That's why it is called paradoxical. And you've got a third condition here, where your flow rate actually, where your stroke volume index is normal, and yet the gradient is low. Now, as I've said before, the reason for the gradient to be low in severe aortic stenosis is because the transvalvular flow rate is low, or stroke volume is low. So what is this condition where the flow is normal and yet the gradient is low? Now, this do happen in patients with significant hypertension, and because of increased afterload, the flow is not affected, but the gradient is. So this is another reason why you get this mismatch in terms of low gradient and low aortic valve area. Now, the question really now is, because it is so important to know what the flow rate is, in order for it to classify as low flow and high flow, and in order for you to know whether the gradient is affected because of low or high flow, we need to be sure that the definition of flow is correct. Now, what is flow? So if you look at this, flow is the volume of blood passing through a structure per unit of time. That is flow. But stroke volume is not flow. Stroke volume is just the volume of blood ejected in systole. So this is not really flow, but just a surrogate marker of flow. So flow is more accurately described as flow rate, which is stroke volume divided by ejection time, meaning it is the rate at which stroke volume is being ejected. So the flow rate can be low and the gradient can be low despite a normal stroke volume, because as the ejection time prolongs, the flow rate will go down despite the same stroke volume. Conversely, if the stroke volume is same, but the ejection time is shortened, the flow rate will go up. Now, also one must remember that flow rate can also be derived according to this equation, because stroke volume is actually LVOT area multiplied by the VTI. So if this is the area, that is the VTI, VTI is distance, and distance divided by time is flow rate, then you have an equation which is area divided by velocity. And this velocity is the measure of the force with which the blood strikes the valve. And hence, it is a better correlate of gradient and AVA than stroke volume, because stroke volume doesn't have any velocity, while flow rate has a velocity incorporated in this, a kinetic energy, and that kinetic energy is converted to the establishment of the gradient. And as you can see, I've shown this slide before. On the left-hand side, transvalvular gradient related to transvalvular flow. But I'll show you an example of this. So this is a patient with low gradient severe aortic stenosis. And this patient has undergone a dovitamin stress echo to increase the flow. And now you can see, if you look at the A shows a stroke volume of 48 ml. And then as the dovitamin is given, the stroke volume doesn't change. And at peak stress, the stroke volume doesn't change. But yet, if you look at the gradient, the gradient across the valve was about 17 or something, and it increases to 31. So the gradient goes up to 31 and the stroke volume doesn't change at all. So it's clear that stroke volume is not contributing to the gradient. So what is contributing to the gradient? Now this is very clear here. You can see the velocity, the mean velocity here is about 69, but at peak dovitamin, the mean velocity has gone up to nearly 100. I can't see it very clearly, but it's about 100. But you can see yourself, you know, the velocity is low here, the velocity is very high here, and that is flow rate we are looking at. So the flow rate has gone up from 164 to about 209, so it's over 200, and that is causing the gradient to increase. And similarly, on the right, you see the relationship between flow rate and aortic valve area. As the flow rate goes up, the aortic valve area also goes up, but the change in aortic valve area is unique because it depends on whether the valve is rigid or severely stenosed, or is it less rigid and therefore it is moderate. So I'll show you what I mean by that. So this is a study, experimental model looking at two groups, one with moderate aortic stenosis, 1.5 centimeters square, one with severe aortic stenosis, 1 centimeter square. And at the bottom you see is the change in flow rate, right? Now what you see here is as the flow rate changes from 100 ml to 200 ml, in those with, moderate aortic stenosis, you see the aortic valve area improves. Now it also improves in the group with severe aortic stenosis, but much less than moderate aortic stenosis. Now once it exceeds 200 ml, and you can see now it has exceeded 200 ml, with those with 1 centimeter square valve, meaning severe aortic stenosis valve, there is no further change. So beyond 200 ml in a truly severe aortic stenosis, meaning it's a rigid valve, the aortic valve area doesn't improve anymore, it stops. While with moderate aortic stenosis, it still continues to improve. And this is a very important concept, because what it means is all you need to do is to see what your flow rate is. If your flow rate is normal, and if the valve area is less than 1, then it is severe, because after that, even if you increase the flow rate, it's not going to change anymore, meaning it is rigid. And so we did a study actually proving this. And in this study, we said resting aortic valve area at normal transaortic flow rate reflects the true valve area in low gradient severe aortic stenosis. And if you look at this data, you will see that even if the ejection fraction is normal, when the patient is stressed, you see the aortic valve area is increasing significantly. Now, even if the stroke volume index is normal, the aortic valve area still increases significantly. But if the flow rate is normal, then the aortic valve area then doesn't change. So 19 patients had a flow rate, aortic valve area which didn't change, meaning this valve is severely stenosed. And this study shows further that under those circumstances where the flow rate is normal, you'll see there are 19 patients, 16 of them had truly severe aortic stenosis as predicted by dovitamin stress echo. While if you look at stroke volume index, though it is normal, only 11 patients had true severe aortic stenosis based on dovitamin stress echo. So in other words, reaching a flow rate of 200 ml per second, and if the valve area is less than 1, then it is severe aortic stenosis. So if you have a patient where the gradient is low, the valve area is low, but the flow rate is normal, it is likely to be severe aortic stenosis. You don't need to do anything else. You send the patient for valve replacement. But where is the proof? Now, I'll just show you another study. Now, so this is regarding the diagnosis of severe aortic stenosis. Now, what about prognosis? So in this study, we looked at the value of transvalvular flow rate in terms of predicting prognosis or mortality in patients with low gradient aortic stenosis after valve replacement. And what it showed is flow rate turns out to be the most significant independent predictor of mortality, right? You can see if the flow rate was more than 200 ml, the patient did well. If the flow rate was less than 200 ml per second, the patient did not do very well. So what it implied indirectly is those who had flow rate of more than 200 ml per second and had a valve area less than 1, they had severe aortic stenosis. So they did well after operation. But those patients who continued to have low flow rate, and these patients were operated, they didn't do well because many had low flow state, and 2, they may not have had severe aortic stenosis. And in fact, the prognostic value was better than stroke volume index. As you can see, it gave greater prognostic value when flow rate was added to stroke volume index. And this was also shown in all patients across all types of aortic stenosis, meaning we looked at 774 patients with, you can see here, normal flow. High gradient aortic stenosis, the normal aortic stenosis that we see, who had a normal flow, but the gradient is high, and these are the ones that we see most of the time. Now, the other group also where we divide into normal flow but low gradient. And then we have low flow but high gradient. Sometimes we do have patients where the flow is down, the gradient still remains high, but that is because the patient had even higher gradient, but as the flow came down, the gradient came down, but it still remains high. So these patients need operation anyway. And the last group is where the patient has low flow, but low gradient. And you can see that even in these 4 groups of patient, the flow rate again came out to be the best predictor of outcome. So flow rate is a robust marker of outcome compared to stroke volume index. This is another study very recently published, just about 2 or 3 months back in JACC. And you can see here what they clearly showed is that if the valve area is less than 1, and if the flow rate is more than 210, so they got a figure of 210, but it is between 200 210, then this patient has a diagnosis of severe aortic stenosis, because these patients, if they're not intervened on, did very badly. So the outcome was really bad with these patients. So the algorithm for is we need to incorporate flow rate in our aortic stenosis assessment. So you look at the aortic valve area, it's less than 1, and if the mean gradient is more than 40, it is severe aortic stenosis, no question. But if the mean gradient is less than 1, then you assess the flow rate. If the flow rate is more than 210 or more than 200 and 210, so any of those, then it is severe aortic stenosis, and this patient should then be treated accordingly. And those who've got transvalvular flow rate of less than 200, here the aortic valve area diagnosis is uncertain, and we are going to come to that, how we make it certain. So the question now is, really in a patients with a normal flow but low gradient aortic stenosis, does aortic valve replacement help? Do they truly have severe aortic stenosis? And this study clearly shows that it does, because you can see that this is comparison to conservative management. Those who had a normal flow rate with valve area of less than 1, the outcome was excellent. And those who underwent medical treatment, the outcome was not good. Again, confirming the fact that if the flow rate is normal, aortic valve area is less than 1, it is severe aortic stenosis. Now, the other interesting part of the study to account for this discordance, so this is another thing, another feature that you need to take into account when assessing discordant aortic stenosis, is you can see here, this is our study, right? Where it is, we're looking at normal flow, low gradient aortic stenosis. And we said that normal flow, low gradient aortic stenosis is severe aortic stenosis. So in this group, you will find that though the gradient is low, it is in the region of 30 millimeter of mercury. And as you can see, the valve area is low, it's about 0.9 to 0.8. Now, what it means is, if the flow rate is normal, the chances are high that these patients will have a gradient of mean gradient of about 30, not 20, not 25, but 30. If it is 20 to 25, then you have to have another close look, whether it is truly severe or not. Now, I say this because of this figure here. So here what it shows is, now this is a study done 12 years ago actually, and it shows a relationship between valve area and mean pressure gradient. And what you see here is, if you look at the fitted line here, you will see that when the valve area drops to less than 1, and if you drop a line from there, the mean gradient is about 25. So actually, a valve area of less than 1 corresponds to a mean gradient of 25. Now here, they took all patients into account, including those with normal flow. Now, if the patient had a normal flow, as I've said, the mean gradient will be about 30, not 25, with the aortic valve area of 1. Now, if you note even further now here, if look at the fitted line, it goes down, and when it crosses 40, then the valve area here is 0.8. So in short, actually a mean gradient of more than 40 corresponds to a valve area of less than 0.8. And the reason why in the guideline it is still 1, despite the gradient being 40, is because to balance the sensitivity and specificity of the guideline. So in other words, a valve area of less than 1 is a very sensitive marker of severe aortic stenosis, but it's not very specific because the gradient is lower. While a 40 millimeter of mercury is a very specific marker of severe aortic stenosis because the valve area comes to 0.8. So that's why they've combined the aortic valve area and the mean aortic stenosis to come to a unified diagnosis. But from the data that we are producing here, what we are saying is, if your flow rate is normal, your mean gradient is likely to be more than 30, and then you're more or less sure that the patient has got severe aortic stenosis, and you don't need to do any further tests, and this patient can be declared as severe aortic stenosis. So we wrote an editorial for this JACC papers and said, time to go with the flow, meaning transvalvular flow. So now we've unraveled all the issues about low gradient aortic stenosis, and now we've defined transvalvular flow status, and despite so the gradient is low, and between 30 and 40, the aortic valve area is low, the transvalvular flow rate is low. Now you have a condition where the ejection fraction is low. So this patient's got truly low flow, low gradient aortic stenosis. And here we don't know what the severity of aortic stenosis is in this group. And similarly, in the second group, though the ejection fraction is normal, the flow continues to be low. And here also we don't know the severity of aortic stenosis. Now here, what do we need to do? Here, in this group of patients with low gradient aortic stenosis, with reduced LV ejection fraction and low flow, we need to increase the flow. We need to normalize the flow to 210. And if when the flow reaches 210, and if the valve area is less than 1, then it is again severe aortic stenosis. Now, according to the guideline, it says when you give dobutamine and if the mean gradient is more than 40, you increase the flow, you increase the gradient, and when it exceeds 40 and the aortic valve area is less than 1, then it is severe aortic stenosis. That's fine. You can take that. Now, there are times where you don't increase the flow rate to that extent. You don't increase the flow rate to increase the gradient to more than 40. There, you do a projected valve area, because then you haven't increased the transvalvular flow rate too much, because the patient doesn't have much contractile reserve, and therefore everything remains as it is. Now there, you can do a projected valve area, provided there's some change in flow rate, and this is a formula for that. Anyway, it will be, you'll have access to this presentation, and this is normalizing to a flow rate of 250, and if the valve area remains less than 1, then it is severe aortic stenosis. So this is another way to overcome lack of contractile, patients with lack of contractile reserve. You can do a projected valve area. So in conclusion, when a patient has discordant aortic stenosis, and I'm now referring particularly to low gradient, low aortic valve area, check the measurements. It's very important to get your diagnosis right. It is quite possible that actually this patient doesn't, these patients don't have low gradient, because if you measure your gradient from another window, the gradient could be more than 60. And this is particularly true in very calcified valve. If the valve is very calcified, then you must really hunt for it. And on the other hand, you measure the other, the other parameters, as I've said before, aortic LV aortic diameter, etc., correctly. Now, after having done all that, after having been sure that this patient does have low gradient, low aortic valve area, then check the flow rate. If it is normal, and if the gradient is over 30, and the valve is calcified, this gives you a mandate of making a diagnosis of severe aortic stenosis straight away without any other investigation. However, if the flow remains low, if the flow rate is low, then you need to increase the flow, and that's where you do a dobutamine, a low-dose dobutamine assessment in patients with low ejection fraction. Now, with normal ejection fraction in paradoxical low-flow aortic stenosis, if the flow is low, dobutamine stress echo is no longer recommended, because when you give dobutamine, you reduce the LV volume to such an extent, you don't actually increase the flow rate anymore. And therefore, you end up with more problems than anything else. And this is particularly true with patients with atrial fibrillation. Now, there it is recommended you send the patient for assessment of aortic valve calcium. And if it is more than 3,000, then it is severe. Thank you very much.
Thank you very much, Prof. That was really a very, very insightful talk. I'm just checking, can Okay, I've shared my videos on. Yeah, I'm unmuted. Excellent, Prof. Thanks so much for that. We've at the moment we've got 3 questions. Just a reminder to our attendees, this is your chance. Okay, so if you would like to ask a question, type it into the Q&A for us, please. Prof, if you're ready, I'm gonna go with the first question. So as you know, there's a lot of.
I can't see the question on the screen, right?
Okay, I will read it to you.
Okay, fine.
Okay, as you know, we've got a lot
sharing
of.
My screen.
Yes, you may. Yeah.
Yeah. Okay.
Okay.
All right. That's great.
All right.
Now
okay.
It's better.
Good. We have quite a lot of rheumatic heart disease still in Africa, as you know. So we've got a question from a clinician asking, I have a patient with rheumatic heart disease. He's got severe mitral valve stenosis and aortic stenosis, presumably also rheumatic, which is difficult to assess. He's just after any thoughts, please. That's the question.
So the question is, the patient has got severe rheumatic stenosis and also aortic valve stenosis. And the reason why it will be difficult to assess aortic valve stenosis is that with severe mitral stenosis, the flow will be low. And therefore, so mitral stenosis is creating a low flow situation. But we also know that by increasing the heart rate, we can increase the flow, right? So you can give still low dose dobutamine, or you can even exercise the patient actually on a bike, and you increase the flow, and if the flow goes up sufficiently, then you can make a diagnosis of severity of aortic stenosis, even in the presence of severe mitral stenosis. But I agree that in these patients, right, the flow may not go up. Then it's difficult to make a diagnosis. But as I've said, you can also take the help of projected valve area here. So even if the flow rate goes up a little bit, you can project it to 250 ml, as I've stated the formula there, and you can have an assessment of aortic valve area still.
Okay, all right. Thanks, Prof. Thanks for that. I trust that answers the question. Okay, if we move on. So, Prof, earlier in the presentation, you've mentioned about the velocity ratio, or the so-called dimensionless valve index, also as a marker of severity. The question is just here: do you use the VTI or just the peak velocities when we quote dimensionless valve index?
Okay. So I haven't actually talked much on that, but yes, dimensionless valve index is a marker of aortic valve area, isn't it? Because you multiply that by the LVOT area and you get the aortic valve area. So your question is it velocity or is it VTI?
Yes, correct. Yeah.
VTI is more accurate because it does. So remember that the LV flow is over a period of time, not at one point. So the velocity is at one point, while the VTI is over a period of time. And similarly, when the aortic valve is stenosed, you can appreciate that the gradient is throughout the period of systole. So taking that into account, the VTI, the ratio of VTI is a more accurate marker of dimensionless index.
Okay, all right. So definitely VTI. Okay, thanks for that. And okay, Prof, the third question is, now I know while I was still working in the UK, the pencil probe was used, also to assess the gradient. So in your practice, I think there are 2 parts to this question. Is there still use for a pencil probe? And if yes, any tips on getting a good gradient, a strong signal? I know it can be very difficult, but if you can share some top tips.
Oh no, I think the importance of using a pencil probe, of course, is it is more sensitive than the other probe because it just looks at the gradient and it doesn't it's not interfered by it looking at the structure of the heart, and therefore it picks up even very weak signals very well. So therefore pencil probe is definitely the technique of choice, I would say, right?
Okay.
So you start off with the probe, with the transducer, without the pencil probe, where you see both the structure of the heart and the Doppler, right? Now, when you do that and you're still not getting a good signal, you switch to the pencil probe. In that particular point, you switch to the pencil probe so that it's in the very same area where you're picking up the velocity more or less well, and therefore you know where it is. So that's what I would do, and that's what we do.
Okay. Okay. Thanks, Ron. I think that will answer the question. If anybody, we've addressed all three questions, but I want to encourage attendees, if there's any more questions. Prof, from my side, just if you can, I don't know if at this point the flow rate equation is routinely used in at least the Africa echo community yet, but can you just please go through the, you said it's stroke volume divided by the left ventricular ejection time.
Yes, that's all it is.
Okay, so all right.
That's all it is. Yeah, so stroke volume, and you take, so the ejection time is calculated in with the LVOT velocity. So you do a LVOT velocity, and you just measure the time interval between the two. You know, the origin of the curve and the end of the curve. So 2 points.
And that will be in milliseconds. It's going to be.
That will be in milliseconds. Yes.
Milliseconds. Okay. Yes. Okay. And a normal flow rate is in more than 210, 20-ish.
Yeah, it's between two. So anything less than 200 is low, and so anything over 200 is normal.
Okay. Okay. And I think in many times we, I don't know if this measurement is routinely available on commercial echo machines. I think it was something that we need to build the calculation in.
Yes, absolutely. Okay. I mean, it's very simple. You know, it's stroke volume. You have the stroke volume. In our machine, David, it's your Philips machine, right? We have it. Yeah. So we just incorporated it. So as soon as we calculate the stroke volume, we put the ejection time in, it gives the flow rate straight away.
Okay, automatically, yeah.
Yeah. Okay, so let me make this clear, David. I know we've got a bit of time. That yes, flow rate is new, no question about that. As I've said, this is something that I popularized from 2013 when I first discovered that this is very useful. Yeah. And you can see how in the year 2020, there's a large paper from that paper was from Boston, from actually Harvard University, where they corroborated this finding of ours. And in fact, in that paper, they clearly said now it should be in the guideline. Okay. It should be in the guideline, and so when the new guideline will come out, flow rate is likely to be incorporated in that. Okay. Because you can see all the evidence how flow rate actually relates to gradient, not stroke volume. Yeah, that was very interesting. I think so. It's going to change, but I agree for the time being. You know, but it's very easy for you to look at flow rate. So whoever's listened to this talk can just shift yourself to flow rate, and David, you just help them in just getting a default where they can assess the flow rate straight away. Just do the ejection time and it's done. Yeah. I think I might have to visit a few of our of our customers and build that equation in. I'll be happy to do so, Prof. Yeah. Prof, I think just from my side, perhaps one more question. I know global longitudinal strain, it's becoming more easy to do. Are there any evidence that suggests that global longitudinal strain can identify patients that would, let's say in a group of patients, severe but asymptomatic aortic stenosis, can GLS unmask patients that would benefit from surgery perhaps earlier? Yeah, no, absolutely. Because I mean, the concept is very clear. Because GLS, which looks at longitudinal function, is a better marker of myocardial function than ejection fraction is. Because ejection fraction is just a volume change, right? It is load dependent. It's very much load dependent. And it's a volume change. It actually is a marker of contractility, but it's just a marker. Just like stroke volume index, right? Stroke volume index is a marker of flow, but it's not flow. Similarly, ejection fraction is a marker of contractility, but doesn't tell us about contractility directly. While longitudinal strain does tell us about the longitudinal fiber contractility. So it does give us that information. And yes, in aortic stenosis, it's not only the longitudinal strain that is affected, it is the radial strain which is affected, the circumferential, all the three strains are affected, but it's easy to do longitudinal strain. And it has been shown to provide prognostic, incremental prognostic value beyond ejection fraction for predicting, valve replacement, mortality, etc. It is indeed a useful tool for one to have. And if the longitudinal strain is markedly reduced in a patient with a normal ejection fraction asymptomatic aortic stenosis, you can make a strong case for replacing the valve.
I see, I understand. Thanks, Prof. We've got just one more question that came in now. It's saying, is there a role for 3D echo in assessing aortic stenosis? I think this is a cardiac anesthesiologist that's asking. So the role of 3D echo in assessing AS.
Yes, I think it is definitely, because remember we talked about LVOT diameter.
Yes, yeah.
Right, which is the greatest source of error. We tend to underestimate LVOT diameter because we are looking at it in only one plane. Right? It's not a circle, so it's not circular. So we are assuming it's a circular, and then we are multiplying it by pi r square, because that's the formula that we are using, assuming it's a circle. Actually, it is an elliptical shape. So in one dimension, it can be smaller than the other dimension. So with 3D, we can actually measure the whole LVOT area. We can actually measure LVOT area directly, and that is likely to be more accurate. But the only problem with 3D, as we all know, is the image quality. If the image quality is good, we get a very good 3D LVOT area. If the image quality is not that good, then we can also mess it up there.
Okay. Yeah. No, 3D, as useful as it is, if the 2D image quality is not great, it's it probably won't help that much.
That's correct.
Okay. All right. Excellent, Prof. It's about bang on 8 o'clock now. I think we've had about 4 or 5 questions. Prof, I think in the interest of time, I think that concludes our 3rd session. So I want to thank you very much for your time. This was extremely insightful. I think there's some very educational takeaways. We spoke about flow rate, and I think that's definitely going to be, I hope our clinical users will definitely consider that. And as you said, it will be part of the guidelines very soon. And it's something, we're looking forward to, and we're very excited about that. I want to thank all the delegates for their participation and engagement throughout the session. Just a reminder, we'll have Dr. Walter Serino. We'll have him back on the 13th and then on the 27th as well for the final talk. So thanks very much for your time. Prof. Senior, again, it's really great to see you again. Thanks for your time and this excellent talk. And with that, thanks for attending and good night.
Thank you. Thank you.
Thanks.
Bye.
Good night.